Welcome to the deep dive. This is where we really aim to cut through the noise, take those incredibly dense, vital surgical texts and sources, and really synthesize them down into pure applied mastery for you.
That's the goal, taking the complex and making it actionable.
And today, our mission is, well, it's pretty monumental, actually. We're doing a total deep dive into the surgical anatomy of the anterior abdominal wall and, of course, that famously treacherous inguinal region.
It truly is the bedrock of abdominal surgery, foundational knowledge.
Absolutely. And our goal here isn't just listing parts. We want you, the listener, to achieve true fluency, linking every single anatomical structure.
To a specific, often high-stakes clinical decision.
Yeah, this is really the elite professional's anatomy review, wouldn't you say?
I would. And what's really striking is that even with all the advances, laparoscopy, robotics, success still boils down to understanding that deep fascia, the precise layering, the exact path of every single vessel and nerve, it's fundamental.
Get it wrong, and the consequences are serious.
Exactly. Misunderstanding how to close the rectus sheath properly or misplacing just one tack down in the inguinal canal. That can be the difference between a smooth recovery and, well, chronic pain or recurrence for the patient.
Okay, so let's map out this journey for everyone listening. We're going to start right at the beginning, tracing the fundamental blueprints, looking at the embryology, how the wall even forms.
Which explains why it sometimes fails, fundamentally.
Right. Then we'll navigate that crucial three-zone system of the rectus sheath, very important for closures.
Absolutely critical.
We'll pinpoint the exact location of the neurovascular supply, which is, vital for things like TP blocks and avoiding nerve damage.
The transversus abdominis plane, yes.
And finally, we'll dedicate significant time to really mapping out the complex architecture of the inguinal floor. That includes those high-stakes vascular and neural hazards, the triangles everyone worries about in laparoscopy.
The triangle of doom, the triangle of pain, we'll dissect those carefully. It's about moving beyond just rote memorization.
To full conceptualization. Understanding the why.
Precisely. So let's begin right at the foundation. Embryology. You really can't grasp the defects without knowing the development.
Okay, so when we talk about the anterior abdominal wall actually forming in the embryo, it's not just one thing. It's multiple structures coming together from different origins, isn't it?
That's exactly right. It's a composite structure, and its formation relies on very coordinated migration and differentiation. You've got two primary contributors. Superficially, there's the ectodermal epithelium that's destined to become the epidermis, the outer layer of the skin.
Okay, the covering.
And then the underlying structural core, that comes from the somatopleuric mesenchyme. Now, this is the layer that gives rise to pretty much all the deep connective tissues.
So the dermis.
The dermis, yes. And critically, the aponeuroses, those tough, fibrous sheets that provide the wall's strength, and also the lamina propria of the parietal peritoneum, the very innermost lining of the abdominal cavity.
And the muscles, the engine of the wall, where do they fit in?
The muscles. They derive from a specific group of cells called the hypaxial population, which originates from the somite dermomyotomes.
Distinct from the back muscles, the epaxial ones.
Completely distinct, yes. These hypaxial cells migrate ventrally, moving into the lateral body wall, and they initially form this sort of generalized premuscle mass.
Okay.
Then, through some really complex interactions with that somatopleuric mesenchyme we just mentioned, this mass starts to cleave, it splits, and differentiates into the three familiar anterolateral muscles.
The obliques and transversus abdominis.
External oblique, internal oblique, transversus abdominis, and also the rectus abdominis muscles centrally.
And that central connection point, the linea alba, how does that form?
That forms from the coming together of the approximation and then the subsequent fusion of the aponeuroses from the right and left rectus muscles. This fusion happens all along the midline, creating that central fibrous raphe. But there's one key exception.
The umbilicus.
Exactly. Right around the umbilical ring, that small area remains slightly separated. It has to accommodate the vessels passing through in the umbilical cord.
Which brings us neatly to the midgut development. Because its journey, or failure thereof, explains those really devastating congenital defects like omphalocele and gastroschisis. What's the critical time frame for the midgut's field trip?
Field trip, that's a good way to put it. It's actually a mandatory physiological herniation. It has to happen.
Right.
And it occurs relatively early in development, spanning stages 15 through 22. So if you translate that, it's roughly 35 to 55 days after fertilization.
Okay.
During this window, the midgut loop grows incredibly rapidly, much faster than the embryonic abdominal cavity can expand to hold it, so it temporarily protrudes out into the extraembryonic pallium, which is housed within the base of the umbilical cord.
And then comes back.
Yes, but only later.
Yeah.
Starting around the 10th week post-fertilization, the abdominal cavity has grown enough, and the midgut begins its complex process of returning and rotating back into its proper place.
And that temporary journey leaves behind some really important anatomical remnants in the adult, doesn't it? What structures do we need to remember passed through that fetal umbilical cord?
Absolutely. There are 4 key structures passing through. Superiorly, you typically have a single umbilical vein, usually the left one, persists carrying that vital oxygenated blood from the placenta.
And its remnant.
Its remnant persists in the adult as the round ligament of the liver, or the ligamentum teres hepatis. You find it within the free edge of the falciform ligament. Inferiorly, there's the allantois, which is connected to the developing bladder. It eventually becomes the urachus.
Right.
Its fibrous remnant forms the single midline median umbilical ligament in the adult.
And the arteries, there were 2 of those.
2 umbilical arteries, yes. They were branches off the internal iliac arteries in the fetus, carrying deoxygenated blood away. After birth, they obliterate, and the remnants form the paired bilateral medial umbilical ligaments. You can see these covered by peritoneum laparoscopically.
This anatomy directly leads us to that critical clinical distinction. When a clinician sees a newborn with an abdominal wall defect, it's all about the sac, isn't it? Omphalocele versus gastroschisis.
It changes everything. The entire management strategy hinges on that single observation. Sac or no sac.
So, omphalocele.
An omphalocele represents a failure of that midgut return we talked about, a failure of midgut reduction, and a failure of the umbilical ring itself to close properly. The herniation occurs directly into the base of the umbilical cord.
And the key feature.
The key diagnostic feature is protection. The herniated organs bowel, sometimes liver, are encased. They're covered by a sac. This sac is composed of an outer amniotic layer and an inner peritoneal layer.
Okay, so contained.
Yep.
And gastroschisis, that's different. The defect is off to the side and exposed.
Precisely. Gastroschisis is thought to result from a different mechanism, likely a failure of the body wall closure itself, a developmental defect usually occurring lateral to the midline, most often just to the right of the umbilicus. And here's the crucial part. There is no hernial sac. None.
Just exposed bowel.
Just exposed bowel floating freely in the amniotic fluid in utero. This exposure leads to a significant chemical irritation, a sort of peritonitis, resulting in a thick, inflammatory, gelatinous exudate covering the bowel loops by the time of birth.
Wow, so that distinction, sac versus no sac, carries enormous clinical weight immediately at birth.
A massive weight. The exposed bowel in gastroschisis presents immediate major challenges. Think about fluid loss, temperature regulation problems, and the high risk of bacterial contamination right after delivery.
So the repair approach must be different.
Very different. Gastroschisis often necessitates what's called a staged repair. You might use a temporary silo, a sterile bag to cover the bowel externally because the abdominal cavity is often underdeveloped and simply too small to immediately accommodate the swollen, inflamed, excoriated bowel. You gradually reduce it over days.
Whereas omphalocele?
With omphalocele, management depends a lot on the size of the defect and what organs are involved, but the protection offered by that sac often allows for a more controlled approach. Sometimes even a primary closure is possible, or at least a less emergent one.
Okay, really clear distinction. Let's transition now from embryology to the established surgical anatomy in the adult. Defining the boundaries of the anterior abdominal wall seems like step 1.
It is. You need to know your playing field. It's generally considered a hexagonal area.
Hexagonal.
Yeah, roughly. Superiorly, its limit is defined by the cartilages of the 7th through 10th ribs, plus the xiphoid process.
Okay.
Inferiorly, it's anchored by the inguinal ligament and the underlying pelvic bones. And laterally, the extent is usually taken as the mid-axillary line on each side.
Got it. Now we absolutely have to drill down on the fascial layers, moving from superficial to deep. This is key for any incision.
Absolutely key. So starting superficially, just under the skin, we have the superficial fatty layer, which most know as Camper's fascia.
Right, Camper's.
Deep to that, particularly prominent in the lower abdomen, is the deeper membranous layer, Scarpa's fascia.
And Scarpa's is clinically important.
Very. It's surprisingly strong, and critically, it's continuous inferiorly. It extends down into the perineum, where it becomes known as callus fascia. This continuity explains how, for example, urine extravasation from urethral injury can track up onto the abdominal wall but is limited inferiorly.
Ah, I see. Any pitfalls with scarpas?
Yes, particularly in children, it can be quite distinct, and sometimes surgeons, especially those less experienced, might mistake it for the actual aponeurosis of the external oblique muscle, which lies just deep to it. You need to ensure you're down to the true fascia.
Okay. And the deepest fascia layer before you hit muscle or extraperitoneal fat?
That would be the transversalis fascia. It's described as thin, yet it's remarkably firm and provides a significant barrier. It lies immediately deep to the transversus abdominis muscle, separating it from the underlying extraperitoneal fat and peritoneum.
And its importance lies in its connections.
Exactly. Its continuity is what makes it so crucial. Superiorly, it's continuous with the fascia covering the underside of the diaphragm. Inferiorly, it blends with the iliac and pelvic fasciae. And maybe most importantly, particularly for inguinal anatomy.
The deep ring.
Yes. At the deep inguinal ring in males, the transversalis fascia is the layer that evaginates. It pushes downwards to form the internal spermatic fascia, which is the innermost covering of the spermatic cord structures.
Okay. That's a very important connection. Now let's get to the muscles themselves, the anterolateral group. Their fiber direction is like the surgeon's internal GPS, right?
There.
Especially for muscle-splitting incision.
Absolutely. The way these three muscles are layered and oriented provides incredible strength, like a natural corset. The external oblique is the most superficial of the three. Its fibers run inferomedially, think hands in pockets direction.
Origin and insertion.
It arises from the outer surfaces of the lower 8 ribs, the 5th through 12th, and inserts onto the outer lip of the iliac crest and the pubic tubercle. Its broad aponeurosis forms the linea semilunaris laterally, and critically, its inferior edge rolls upon itself.
Form the inguinal ligament.
Precisely. It forms that tough, free edge running from the acis, the anterior superior iliac spine, down to the pubic tubercle. That's a key landmark.
Okay. Deep to the external oblique, we find the internal oblique.
Correct. And its fibers run roughly perpendicular to the external oblique, fanning out anteromedially. This crosshatch pattern is what gives the abdominal wall so much tensile strength.
Right, like plywood layers.
Exactly like plywood.
Mhm.
Now, there's actually a little bit of anatomical controversy, or at least ongoing discussion, about the precise origin of its very lowermost fibers.
Oh, what's the debate?
Well, traditionally, it's taught that they arise directly from the lateral part of the inguinal ligament. However, more detailed anatomical studies suggest that many of these fibers might actually originate from the adjacent iliopsoas fascia.
Does that distinction matter clinically?
It might seem minor, but it speaks volumes about the biomechanics. It relates to how the lower abdominal wall dynamically protects the inguinal canal, that shutter mechanism we'll discuss later. It hints that the muscle action is linked more deeply than just to the superficial ligament.
Interesting nuance. And the deepest layer, the transversus abdominis.
Yes, the innermost of the flat muscles. As the name implies, its fibers generally run transversely, horizontally, providing that deep circumferential compression like a girdle.
Where does it originate?
It has a very wide origin. From the inner surfaces of the lower 6 costal cartilages, the thoracolumbar fascia posteriorly, the inner lip of the iliac crest, and laterally from the iliopsoas fascia again. Its lowermost fibers also tend to arch downwards.
And inferiorly, the aponeuroses of the internal oblique and transversus abdominis fuse together,
In many individuals, yes, they fuse medially.
creating the structure known as the conjoint tendon.
Exactly, the conjoint tendon, or sometimes called the inguinal aponeurotic falx. This fused structure then inserts onto the pubic crest and the pectineal line, just behind the superficial inguinal ring.
And its role.
It's a critical structure for reinforcing the medial posterior wall of the inguinal canal, right behind the superficial ring. Surgeons historically relied on suturing to it in hernia repairs like the Bassini. It's meant to buttress that area against pressure.
But you said in many individuals, it's not always robust.
That's a crucial point. While textbooks often depict it as this strong, clearly defined tendon, in reality, in a significant number of people, it's not a true fusion. It might be weak, attenuated, or the muscles might insert separately. This variability is a major reason why Hesselbach's triangle can be inherently weak and prone to direct hernias. You can't always count on a strong conjoint tendon being there.
Okay, let's shift our focus now to the central pillar, the powerhouse of the abdominal wall, the rectus abdominis muscles and their enclosing sheath. This is really ground zero for most midline surgical approaches and unfortunately a lot of complex hernias.
Absolutely. You can't operate effectively in the abdomen without a solid grasp of the rectus sheath. The rectus abdominis itself is that long, strap-like muscle running vertically on either side of the midline.
Bounded by.
Medially, it's bounded by the linea alba, that central fibrous raphe. Laterally, its edge corresponds to the linea semilunaris. It spans a huge distance vertically.
Attachments.
Superiorly, it attaches to the anterior surfaces of the 5th, 6th, and 7th costal cartilages and the xiphoid process. Inferiorly, it has a strong attachment to the pubic crest and the pubic symphysis.
Now those tendinous intersections or inscriptions are an interesting feature. They look like horizontal bands across the muscle. Why do they only attach anteriorly?
That's a great observation. The tendinous intersections are indeed fibrous bands. Typically, you find one near the xiphoid, one near the umbilicus, and usually one or two in between.
Like a six-pack structure.
Exactly. They create that six-pack look by dividing the muscle belly. Functionally, this allows for more localized contraction, which is important for posture, flexing the trunk, and stabilizing the pelvis. But anatomically, they adhere firmly only to the anterior layer of the rectus sheath.
Not the posterior layer.
No posterior attachment. This is functionally quite important because it allows the rectus muscle to slide freely against the posterior sheath and underlying fascia during trunk movements and respiration.
But surgically.
Surgically, it means if you're making a transverse incision, like a Fanon style or an upper abdominal transverse cut that crosses the rectus, you must transect these tendinous bands to allow the muscle to retract adequately and give you the exposure you need. You can't just split the muscle between them.
Got it. And we should probably briefly mention the pyramidalis muscle. It seems like a bit of an anatomical afterthought sometimes.
It kind of is. Pyramidalis is a small triangular muscle that sits directly anterior to the inferior part of the rectus abdominis within the sheath. Its highly variable estimates suggest it's absent in anywhere from 10% up to maybe even 70% of individuals.
So often not there, but if it is.
If it is present, and a surgeon is performing a low midline laparotomy, extending the incision down towards the pubis, they need to be aware of it. Because the linea alba actually lies behind the pyramidalis in that lowest zone, the muscle itself needs to be divided or retracted to properly access and incise the linea alba deep to it.
Okay, good practical point. Now, the absolute critical knowledge. The rectus sheath itself isn't uniform. It has that three-zone system based on its relationship to the arcuate line. This dictates everything about midline closure.
This three-zone concept is non-negotiable for surgeons. You have to know it to avoid complications like incisional hernia or inadequate closure. The sheath's composition changes significantly.
So let's break it down. Zone 1, superior to the costal margin. What's the structure there?
Okay, zone 1, right up high. Here, the rectus muscle essentially lies directly on the costal cartilages. There's no fleshy muscle behind it posteriorly in terms of the flat abdominal muscles. Therefore, the posterior rectus sheath is considered absent in this zone. It's replaced by bone and cartilage.
So the anterior sheath.
The anterior sheath is formed only by the aponeurosis of the external oblique muscle as it passes over the rectus. Closure here is relatively simple. You close the skin, subcutaneous tissue, and that single anterior sheath layer.
Okay, now zone 2, this is the biggest area, right? From the costal margin down to that landmark, the arcuate line.
Correct. Zone 2 is where the sheath is classically described and where midline strength is really maximized due to the layering. Here, the aponeurosis of the internal oblique muscle does something interesting. It splits.
Oh, plus.
Yes, it splits into an anterior and a posterior lamella, or layer. The anterior sheath in zone 2 is formed by the aponeurosis of the external oblique plus the anterior split portion of the internal oblique aponeurosis.
And the posterior sheath.
The posterior sheath is formed by the posterior split portion of the internal oblique aponeurosis, joining together with the aponeurosis of the deepest muscle, the transversus abdominis. So you have distinct, strong anterior and posterior layers.
Got it. Strong enclosure. Now, zone 3, inferior to the arcuate line, also known as the line of Douglas. What happens here?
Below the arcuate line, there's a major shift. All three aponeuroses from the external oblique, the internal oblique, which no longer splits, and the transversus abdominis all pass anterior to the rectus muscle and blend together.
So a really thick anterior layer.
Exactly. This creates a very thick, robust anterior sheath. But because all the aponeuroses have gone anteriorly...
The posterior sheath is absent again.
Correct. The posterior sheath is absent below the arcuate line. The rectus muscle now lies directly on the underlying, slightly thickened transversalis fascia and extraperitoneal fat.
So the surgical implication is crystal clear. Only in zone 2, Between the ribs and the arcuate line, do you need to meticulously identify and close two distinct aponeurotic layers, the anterior and the posterior sheaths, for a secure midline repair?
That's absolutely right.
Whereas above the ribs, zone 1, and below the arcuate line, zone 3, you're essentially closing only the anterior sheath.
Precisely. In zones 1 and 3, you close a single, albeit very strong in zone 3, anterior layer. Understanding that anatomical transition point, the arcuate line, is paramount. If you try to find and close a posterior sheath way down low in zone 3, you're likely just grabbing transversalis fascia, fat, or even peritoneum, which adds no strength and risks injury.
That knowledge prevents both inadequate closure up high and unnecessary, potentially harmful dissection down low.
Exactly. It dictates where you place your anchoring sutures and what tissue you should be incorporating. It's about understanding the biomechanics. In zone 2, you're closing a split aponeurosis. In zone 3, you're closing a massive integrated fascial plate anteriorly.
Okay, let's look at the midline structures themselves now. The linea alba isn't uniform either, is it?
No, it's not. The linea alba, that central tendinous raft formed by the decussating fibers from both sides, is generally quite thin. But crucially, biomechanical studies and clinical observation show it significantly weaker and thinner in its inferior portion, below the umbilicus, compared to its superior aspect above the umbilicus.
And that explains.
That inherent infraumbilical weakness likely contributes to the higher incidence of acquired midline hernias in that region, especially after stresses like multiple pregnancies or conditions causing chronically increased intra-abdominal pressure like obesity or ascites.
Speaking of hernias, let's clarify the terminology for midline protrusions. We hear epigastric hernia, diastasis recti.
Right. An epigastric hernia is a true fascial defect occurring above the umbilicus, usually in the superior linea alba. It typically involves a protrusion of extraperitoneal fat or sometimes peritoneum and omentum through that small defect.
And diastasis recti.
Or DRAM. Diastasis of the rectus abdominis muscles, DRAM, is different. It's not a true hernia. It's characterized by a widening and thinning of the entire linea alba, causing the two rectus muscles to separate further apart. You often see it in postpartum women or individuals with central obesity.
And the key clinical difference between DRAM and a true hernia is the risk factor.
That's the absolute critical distinction for surgical decision-making. DRAM, while it can be cosmetically bothersome and sometimes associated with core weakness, represents a laxity of the linea alba, not a discrete hole or fascial defect. Because the peritoneum remains intact deep to the thinned linea alba, there is virtually no risk of incarceration or strangulation of bowel or omentum.
So surgery for DRAM is usually considered cosmetic or for functional core improvement.
Correct. Whereas a true epigastric or umbilical hernia involving a fascial defect carries a genuine risk of trapping contents, leading to potential strangulation, which is a surgical emergency. You must differentiate.
Okay. And finally, regarding the umbilical ring itself, we have congenital versus acquired hernias there too.
Yes. True umbilical hernias are typically congenital. They represent a failure of the umbilical ring, that fibrous cicatrix where all the fetal ligaments fused or passed through to fully close after birth. These are very common in infants, especially premature ones, and the vast majority resolve spontaneously by age 3 or 4 as the ring naturally fibroses and closes.
So often watchful waiting is appropriate.
Often, yes, unless it's unusually large or persists beyond early childhood. Paraumbilical hernias, on the other hand, are the acquired adult version. These typically don't occur through the true umbilical scar itself, but rather push through a weakness in the linea alba immediately adjacent to the umbilicus, usually just superior to it.
And the risk profile.
Because they're pushing through a relatively narrow, rigid fascial opening created by acquired weakness, often related to obesity, pregnancy, ascites, paraumbilical hernias have a significantly higher risk of incarceration and strangulation compared to the common congenital umbilical hernia. They often require surgical repair more promptly.
All right, moving deeper now, beyond the fascia and muscle layers, let's map out the critical conduits, the nerves and blood vessels that supply and wire the anterior abdominal wall. Getting this wrong during surgery can lead to, well, significant hemorrhage or chronic debilitating pain.
Absolutely. This neurovascular anatomy is incredibly relevant clinically. The primary innervation comes from the lower intercostal nerves, specifically the thoracoabdominal nerves, which are the continuation of the ventral rami of T6 through T11.
T6 to T11.
Plus the subcostal nerve, which is T12, and then contributions from the first lumbar nerve root, L1, via the iliohypogastric and ilioinguinal nerves, which supply the lowest part of the abdomen and the groin region.
And it's important to remember these are all derived from the ventral rami of the spinal nerves.
Yes, the ventral rami, that's key.
Now, what's really fascinating from a surgical perspective is the specific anatomical niche these neurovascular bundles occupy. It makes them both vulnerable during incisions, but also potentially accessible for targeted pain management.
That's exactly the point. They travel together artery, vein, and nerve within a distinct plane, the so-called neurovascular plane. And this plane is located precisely between the internal oblique muscle and the transversus abdominis muscle. That's the critical location to remember.
Between internal oblique and transversus abdominis.
Correct. As these segmental nerves and vessels emerge from laterally, they run in an inframedial direction within this plane, eventually piercing the rectus sheath laterally to supply the rectus muscle and the overlying skin towards the midline.
So, incisions risk cutting them.
Any incision that cuts through the musculature laterally, especially oblique or transverse incisions like a cocher or even flank incisions, risks transecting these segmental nerves. The result can be sensory loss, numbness, paresthesias, tingling or burning, or even motor weakness and bulging in the denervated segment of the abdominal wall.
But this very specific location also gave birth to the transversus abdominis plane block, the TAP block, right?
Exactly. The entire rationale behind the TA block is to leverage this anatomy. By injecting a long-acting local anesthetic into that precise potential space, the plane between the internal oblique and the transversus abdominis aponeuroses laterally, you can effectively bathe those thoraco-abdominal nerves, T6, T12, and sometimes ilioinguinal, iliohypogastric, L1, in anesthetic,
Providing analgesia to the abdominal wall.
providing somatic analgesia to the skin, muscles, and parietal peritoneum of the anterior and lateral abdominal wall, which is fantastic for postoperative pain control after various abdominal surgeries.
Now, while ultrasound guidance is definitely the gold standard for TA blocks today for accuracy and safety,
Absolutely.
understanding the classic landmark guided technique is still a really good way to cement the anatomy. Can you walk us through that, particularly the double pop sign people talk about?
Sure. The landmark technique typically targets the injection point within the triangle of Petit. Remember that triangle? Bounded inferiorly by the iliac crest, posteriorly by the edge of the latissimus dorsi muscle, and anteriorly by the posterior border of the external oblique muscle.
Okay, the lumbar triangle.
Yes. So the clinician advances a blunt-tipped needle perpendicular to the skin in this region. They rely entirely on tactile feedback, feeling the layers give way. The first distinct pop or loss of resistance signifies the needle tip penetrating the tough aponeurosis of the external oblique muscle.
Pop number one.
Pop number one. Then, as the needle advances further, it passes through the substance of the internal oblique muscle. The second, usually more subtle, pop or loss of resistance indicates that the needle tip has entered the loose areolar tissue of the plane between the internal oblique and the underlying transversus abdominis muscle. That's the target zone.
The double pop. External oblique, then internal oblique transversus plane.
That's the idea. Of course, the feel can be variable. Fascial layers aren't always distinct, hence why ultrasound is now preferred to visually confirm placement and avoid inadvertent injection elsewhere, like intramuscularly or intraperitoneally. But the concept relies on feeling those two key layers.
Very clear. Okay, let's switch to the vascular supply. Huger zones provided a framework, but let's focus on the major vessels surgeons really worry about, particularly within or near the rectus sheath.
Right. The two dominant vertically oriented vessels are the superior and inferior epigastric arteries.
Start superiorly.
The superior epigastric artery is essentially the terminal branch of the internal thoracic artery, also called the internal mammary artery. It descends from behind the costal margin, enters the rectus sheath, and runs posterior to the rectus abdominis muscle, staying within that posterior sheath envelope, at least above the arcuate line.
Posterior to the muscle.
Okay.
And the inferior one.
The deep inferior epigastric artery has a different origin. It arises inferiorly from the external iliac artery, just superior to the inguinal ligament. It then angles superomedially, pierces the transversalis fascia, enters the rectus sheath low down, and ascends superiorly. Crucially, it also travels primarily between the rectus abdominis muscle belly and the posterior rectus sheath.
So both major vessels are deep to the muscle within the sheath.
Generally, yes, within the confines of the sheath, posterior to the muscle bulk, and they have a very important meeting point.
The anastomosis.
Yes, the superior and deep inferior epigastric arteries form a robust anastomosis, typically located somewhere just superior to the level of the umbilicus. This provides a critical collateral pathway between the subclavian system via internal thoracic and the external iliac system.
Now, for safety, especially in laparoscopic surgery where visualization can be limited. Knowing how far these vessels typically are from the midline is crucial for trocar placement.
Absolutely critical to avoid hemorrhage. Several anatomical studies, like the one by Saber and colleagues, have measured this carefully. The data consistently show that these major epigastric vessels are situated typically between 4 and 8 centimeters lateral to the midline.
4 to 8 centimeters. Any specific level data?
Yes, for instance, right at the level of the umbilicus, they're often found around 5.6 to 5.9 centimeters out laterally from the midline on average.
So the clinical takeaway.
The strong clinical recommendation based on this anatomy is that when placing lateral trocars, you must aim for a minimum distance of 8 centimeters lateral to the midline. This provides a reasonable safety margin to stay lateral to the main trunks of both the superior and deep inferior epigastric arteries and their larger perforating branches.
Stay wide. 8 centimeter minimum. Okay. Now, we absolutely must elaborate on that high-stakes clinical scenario involving the deep inferior epigastric artery. This comes up frequently because it connects abdominal wall surgery to potentially distant, serious vascular consequences.
This is a vital clinical correlation, a potential pitfall every surgeon needs to appreciate. Imagine you have a patient with significant pre-existing peripheral vascular disease. Specifically, let's say they have aortoiliac occlusive disease, significant blockages in their aorta or common external iliac arteries supplying the legs.
Okay, common scenario.
In such a patient, the body is smart, it tries to compensate, it develops collateral circulation pathways to bypass the blockages, and one of the key collateral pathways that can develop is flow coming down the internal thoracic artery into the superior epigastric, across that anastomosis near the umbilicus we just talked about, and then retrograde down the deep inferior epigastric artery.
To feed the external iliac artery below the blockage.
Exactly. To feed the external iliac and subsequently the common femoral artery, providing crucial blood supply to the leg that would otherwise be ischemic. The deep inferior epigastric artery becomes a lifeline for that leg.
So the danger.
The danger arises if a surgeon, unaware of this patient's specific vascular status and reliance on this collateral, inadvertently ligates or injures the deep inferior epigastric artery during a procedure. This could happen during a low-quadrant laparoscopic port insertion, maybe during a tram flap harvest for breast reconstruction, or even during aggressive lateral retraction in an open pelvic case.
And the consequence is sudden leg ischemia. Catastrophic.
Potentially catastrophic, yes. The patient might present post-operatively with sudden acute claudication, leg pain with walking, rest pain, or even signs of critical limb ischemia like coldness, pallor, and sensory motor deficits. The surgeon realizes, too late, that they've interrupted the only significant blood supply remaining to that limb distal to the pre-existing iliac occlusion.
Wow. So the take-home message is a thorough preoperative vascular history, and assessment is absolutely paramount before any procedure that puts the deep inferior epigastric artery at risk, especially in the lower abdomen or in patients with known PVD risk factors.
Paramount. You need to consider if that vessel might be serving as a critical collateral.
Okay. Finally, just briefly on the drainage system's veins and lymphatics.
Sure. Venous drainage generally follows the arterial supply. So the epigastric veins drain into the internal thoracic veins superiorly and the external iliac veins inferiorly. Superficial veins drain into the axillary system above the umbilicus and the femoral system below.
Lymphatics. Also divided by the umbilicus.
Yes, the umbilicus acts as a watershed for superficial lymphatic drainage. Above the umbilicus, lymph generally flows upwards towards the axillary lymph nodes. Below the umbilicus, it drains downwards to the superficial inguinal lymph nodes.
And deep drainage.
Deep lymphatic drainage follows the major vessels, heading towards the peristernal nodes along internal thoracic, lumbar nodes along aorta IVC, and the external common iliac nodal basins.
And surgeons sometimes use transillumination.
Yes, especially during laparoscopic entry in thinner patients. Shining a bright light through the abdominal wall, transillumination, can sometimes help visualize the larger superficial veins, like the superficial epigastrics, allowing the surgeon to make their initial incision or place their Vera's needle, avoiding these vessels to minimize superficial bleeding and hematoma formation.
Okay, so we've meticulously mapped the territory, the layers, the muscles, the vessels, the nerves. Now let's use that map to discuss the surgical approach itself. The incisions. Manget's classic principles still hold true, right? Accessibility, extensibility, and security.
Absolutely. Those three words encapsulate the goals of any surgical incision. You need adequate accessibility to the target pathology. The incision must be extensible if you need wider exposure than initially planned. And critically, the closure must provide long-term security against wound breakdown and hernia formation while minimizing damage.
So you're always balancing exposure needs against potential harm, nerve damage, muscle damage, coracostomesis, hernia risk.
It's always a trade-off. You need to choose the incision that provides the best balance for the specific procedure and patient.
Let's start with the most common, the vertical incisions, the midline.
The midline incision really is the workhorse of abdominal surgery, isn't it? Its main advantages are speed, it's quick to make, and versatility. It potentially provides access to the entire peritoneal cavity from diaphragm to pelvis, and because it goes through the relatively avascular linea alba, it avoids cutting major muscle bellies or nerves.
But the downsides are significant too.
They are. The major disadvantages are primarily threefold. First, cosmesis. It runs perpendicular to Langer's lines, natural skin tension lines, often resulting in wider, more noticeable scars. Second, it's generally considered more painful postoperatively compared to transverse incisions. And third, and perhaps most importantly, it suffers from the highest long-term risk of incisional hernia formation, with rates reported anywhere from 5% up to 20% or even higher in some series.
Wow, up to 20%. Any specific technical points or warnings about making a midline incision?
A couple of key things. For better exposure up high, particularly for upper gastrointestinal or hepatobiliary surgery, sometimes excising the xiphoid process can gain you an extra valuable 3 to 4 centimeters of transverse width at the top of the incision.
Okay.
And crucially, when extending the incision below the umbilicus towards the pubis, extreme caution is needed, especially if the patient hasn't been catheterized. The bladder dome can rise significantly out of the pelvis when full. The standard technique is to open the peritoneum at the superior end of the infraumbilical incision first, under direct vision, and then extend downwards carefully, always staying precisely in the midline to avoid inadvertent and potentially catastrophic bladder injury near the pubic symphysis. Urinary catheter placement is mandatory before making a low midline incision.
Absolutely critical safety point. Now, what about the perimedian incision? We don't see it used as much anymore, but understanding its anatomy is still relevant.
True, it's largely fallen out of favor. The perimedian incision runs vertically but parallel and lateral to the midline, usually over the rectus muscle belly. The anterior rectus sheath is opened, and the rectus muscle itself is then retracted laterally to access the posterior sheath and peritoneum.
Why did it fall out of favor?
Well, while it was theoretically thought to have a slightly lower incisional hernia rate compared to the true midline because the muscle covers the fascial suture line, it has major drawbacks. The lateral retraction of the rectus muscle inherently risks damaging the segmental motor nerves entering laterally, potentially denervating part of the muscle. And low down in the abdomen, the deep inferior epigastric artery almost always lies directly in the path and requires ligation, which adds operative time and carries that vascular risk we discussed earlier, especially if it's a critical collateral.
Okay, makes sense why it's less popular. Let's contrast those vertical cuts with transverse incisions.
Transverse incisions generally offer superior cosmetic results because they tend to follow Langer's lines more closely. They are also often preferred in infants and young children because their abdomens are relatively wider and shorter, making transverse access more natural.
And the nerve issue.
Functionally, transverse incisions have an advantage regarding nerve supply. Because the rectus abdominis receives segmental innervation from multiple thoracoabdominal nerves entering laterally, transecting the muscle fibers transversely usually only denervates a small segment of the muscle. Unlike damaging a single nerve laterally with retraction, like in perimedian, which could paralyze a larger portion.
The classic example is the Pfannenstiel.
Exactly. The Pfannenstiel incision is that curved transverse incision made within the suprapubic skin crease. It's excellent cosmetically and provides good access to the pelvic organs commonly used in GYN and urology. Its main limitation is exposure. It's hard to extend significantly upwards, and laterally as you extend it, you run the risk of injuring the iliohypogastric nerve.
Got it. And oblique incisions, used for more specific organ access.
Yes, oblique incisions follow the direction of muscle fibers or run parallel to the costal margin or inguinal ligament. The Kocher incision, or subcostal incision, is the classic example for accessing upper abdominal viscera like the gallbladder, liver, or spleen. It runs parallel to the costal margin.
Downsides of Kocher.
It requires dividing the rectus muscle and ligating the superior epigastric artery. As the incision extends laterally, the surgeon must be careful to identify and preserve the 9th thoracic nerve, which runs just below the rib margin, to avoid denervation of the upper rectus.
And the other common oblique is the McBurney.
The McBurney or gridiron incision, famous for appendicectomy. It's a muscle-splitting incision in the right lower quadrant. You incise the skin obliquely, then split the fibers of the external oblique along their direction. Then you bluntly separate the underlying internal oblique and transversus abdominis fibers, again parallel to their grain, to reach the peritoneum.
Minimizes muscle damage, but still risks.
Still carries a risk, primarily to the iliohypogastric nerve during retraction, which can lead to numbness or pain in the groin regions postoperatively.
Okay, now let's move to reconstruction. When you have a large defect, maybe from a previous failed closure or trauma, and primary fascial closure isn't possible without tension, we need component separation techniques. The goal is always tension-free closure of the linea alba, right?
Absolutely. Tension is the enemy of durable hernia repair. Component separation techniques are designed to mobilize the patient's own tissues, the musculofascial layers, medially to allow for that tension-free midline closure, often augmented with mesh.
Let's start with the anterior component separation, the Ramirez technique.
Yeah.
How does that work?
The anterior component separation achieves medial advancement by releasing the most superficial layer laterally. Specifically, the surgeon makes a longitudinal incision through the aponeurasis of the external oblique muscle, just lateral to the linea semilunaris, the edge of the rectus sheath. By dividing this aponeurosis and often dissecting the external oblique off the underlying internal oblique, you create a large myofascial advancement flap consisting of the rectus muscle and the intact internal oblique transversus complex. This flap can then slide medially.
How much advancement can you get?
Quite a bit. At the level of the waistline, this technique can provide up to 10 centimeters of medial advancement per side, so potentially closing defects up to 20 centimeters wide. You get less advancement higher up near the ribs or lower down near the pubis.
Okay, that's significant mobilization. Now, the retromuscular repairs have gained enormous popularity, partly because they allow placement of large meshes in a well-vascularized space away from the skin. The Rive-Stoppa technique is foundational here.
It really is. The Rive-Stoppa technique, or retromuscular sublay repair, involves developing a space behind the rectus abdominis muscles but in front of the intact posterior rectus sheath, or transversalis fascia, below the arcuate line.
Behind the muscle in front of the posterior layer.
Exactly. You dissect this potential space laterally, usually out to the linea semilunaris. This mobilization allows the posterior sheath layers from both sides to be sutured together in the midline, if possible, recreating the linea alba deep down. Then, a large piece of prosthetic mesh is placed within this retromuscular space, the sublay position. The mesh is well separated from the skin incision and also from the intra-abdominal contents by the closed posterior sheath. It's in a well-vascularized plane between muscle layers, promoting integration. This technique typically allows for about 3 to 5 centimeters of medial fascial advancement per side.
And for truly massive defects, where even Rive-Stoppa isn't enough, we move to transversus abdominis release, or TAR. This seems like a much deeper, more extensive dissection.
It is. TAR is essentially an extension of the Rive-Stoppa concept, designed for bridging very large, complex abdominal wall defects. It starts with the same retromuscular dissection, but then the key step involves intentionally dividing the posterior rectus sheath near the linea semilunaris.
Dividing the posterior sheath.
Yes, you incise the posterior sheath, which is mainly the transversus abdominis aponeurosis at this level. Then, you carefully divide the underlying transversus abdominis muscle fibers vertically. This allows you to bluntly dissect and develop a plane behind the transversus abdominis muscle, essentially separating it from the underlying transversalis fascia and peritoneum.
Creating a massive retromuscular pre-peritoneal space.
Precisely. This creates an enormous space extending far laterally, allowing placement of a very large sublay mesh, and enabling dramatic medial advancement of the rectus complex for fascial closure, even in defects exceeding 15 to 20 centimeters.
But it sounds technically demanding. What's the most critical structure to preserve during that TAR dissection to avoid complications like muscle necrosis?
The absolute critical detail during TAR is the meticulous identification and preservation of the perforating thoraco-abdominal neurovascular bundles. Remember those nerves and vessels running between the internal oblique and transversus?
Yes.
As they come medially, they perforate through the lateral aspect of the rectus sheath to supply the rectus muscle. During TAR, the incision releasing the transversus abdominis muscle must be made slightly medial to where these perforators enter the rectus sheath, typically about 0.5 to 1 centimeter medial, to the linea semilunaris proper.
Go medial to the perforators.
Yes. If you make your TAR incision too far laterally, you will transect these vital neurovascular bundles. Injury to these vessels and nerves causes immediate partial denervation and potentially significant ischemia of the rectus muscle flap you're trying to mobilize, compromising the entire reconstruction. Preservation of these perforators is paramount.
Very important technical point. Okay, shifting gears slightly now, let's quickly review the fundamental methods surgeons use just to get into the abdomen laparoscopically. Open versus closed entry techniques.
Right. Establishing pneumoperitoneum safely is the first step of any laparoscopic procedure. The open entry technique, often called the Hassan technique after its originator, involves making a small skin incision, usually at the umbilicus.
Incision first?
Yes. Then you dissect down under direct vision, incise the fascia, Hernia alba, and the peritoneum, confirming entry into the abdominal cavity visually. Stay sutures are often placed in the fascia, and a special blunt-tipped trocar, Hassan trocar, with an olive sleeve, is secured into the defect to create an airtight seal.
Advantages of open.
Its main advantage is avoiding blind puncture. Studies suggest it might be associated with a reduced rate of failed access attempts compared to blind techniques, and potentially a lower risk of major vascular injury, although bowel injury can still occur.
Hazards.
The main hazard specific to the open technique is if your initial fascial incision is slightly off-center or doesn't fully penetrate the peritoneum properly. You can end up insufflating CO2 gas into the extraperitoneal space or even just the subcutaneous tissue, leading to significant subcutaneous emphysema, which can be alarming, although usually benign.
Okay. And the closed techniques.
Closed techniques rely on blind or semi-blind puncture. The classic method is the Verus needle technique. You insert a spring-loaded Verus needle, usually at the umbilicus or Palmer's point in the left upper quadrant, perform safety tests to confirm intraperitoneal placement, though these tests aren't foolproof, insufflate the abdomen with CO2, and then blindly insert the first sharp trocar.
High risk of blind injury.
That's the concern, yes. Blind insertion of both the Verus needle and the first trocar carries a risk of injuring underlying bowel or major retroperitoneal vessels like the aorta, vena cava, or iliacs, especially in thin patients or those with previous surgery and adhesions.
Any alternatives to pure blind entry?
Yes, another closed approach is direct trocar entry. This often uses an optical trocar, which has a camera integrated into its tip or allows a scope to be placed inside during insertion. The idea is to visualize the tissue layers as the trocar advances, theoretically allowing the surgeon to see and avoid bowel or vessels. However, visualization can be obscured and injuries still occur. The choice between open, Verus, and direct trocar entry remains somewhat controversial and often depends on surgeon preference and experience.
All right, let's descend into the inguinal region. This area is a masterclass in anatomy, an inherent structural weakness, the inguinal canal, that's dynamically defended. We need to start by anchoring ourselves with the key ligaments deep down.
Absolutely. Understanding the ligamentous framework is essential. Superficially, of course, we have the inguinal ligament, that rolled edge of the external oblique aponeurosis running from the ACIS, anterior superior iliac spine, to the pubic tubercle.
Okay, the familiar one.
But medially, as it approaches the pubic tubercle, some of its deeper fibers splay out posteriorly and inferiorly, attaching onto the pectineal line of the superior pubic ramus. This triangular extension is the Lacanor ligament, also known as Gimmernott's ligament. It forms the medial border of the femoral ring.
Lacanor ligament, and deep to that.
Running along that pectineal line itself is a very strong fibrous band called the pectineal ligament, or Cooper's ligament. This is periosteum, essentially. It provides an incredibly robust anchoring point for sutures, much stronger than the inguinal ligament itself. It's the key structure used in repairs like the McVeigh repair for femoral hernias.
Cooper's ligament, the strong anchor. Now, there's another important band running deep, parallel to the inguinal ligament.
Yes, that's the iliocubic tract. This is a deeper structure, often harder to visualize distinctly, but it's formed by a condensation of the transversus abdominis aponeurosis and the overlying transversalis fascia. It runs parallel to the inguinal ligament from the ACIS region towards the superior pubic ramus, and it helps to define the inferior border of the deep inguinal ring. It's a key landmark in laparoscopic hernia repair from the inside view.
Iliopubic tract, the deep parallel band. Okay.
Where?
With those anchors defined, we inevitably arrive at the area of inherent weakness. Hasselbalch's triangle.
The infamous triangle. This is the anatomical space where direct inguinal hernias occur. Its boundaries are critical to know.
Define them for us.
Superiorly, or superolaterally, really, the boundary is the deep inferior epigastric artery and vein as they course upwards. Medially, the boundary is the lateral border of the rectus sheath, and inferiorly, the base of the triangle is formed by the inguinal ligament.
Inferior epigastrics,
Yeah.
rectus sheath, inguinal ligament.
Correct. And the floor of this triangle is formed primarily by the transversalis fascia. And as Dr. Nyhus famously pointed out decades ago, the transversalis fascia in this specific region, Hasselbalch's triangle, possesses little intrinsic strength. It's naturally thin and weak here.
Making it the prime spot for acquired protrusions when intra-abdominal pressure rises.
Exactly. It's the path of least resistance for a direct hernia bulge.
Now, before we talk hernia types, let's discuss that dynamic defense, the shutter mechanism that's supposed to protect the inguinal canal when pressure increases. It's not just a passive tube, is it?
Not at all. The inguinal canal is designed to be protected by active muscle contraction. This shutter mechanism kicks in automatically when intra-abdominal pressure rises. Think coughing, sneezing, lifting heavy objects. It relies on the coordinated contraction of the two deep, flat muscles, the internal oblique and the transversus abdominis.
What do they do specifically?
Their contraction applies two crucial forces simultaneously, working together like a closing gate. First, the arching lowermost fibers of both muscles, which normally loop over the spermatic cord, are pulled downwards and medially. This action effectively lowers the roof of the canal, compressing the cord against the inguinal ligament floor and reinforcing the posterior wall.
Okay, compression from above.
Second, and perhaps more subtly, the contraction of the transversus abdominis also pulls on the transversalis fascia sling around the deep inguinal ring, specifically via a thickening called the interfoveolar ligament. This tension pulls the medial boundary of the deep ring superiorly and laterally.
Closing the entrance.
Exactly. It narrows the opening of the deep inguinal ring, making it harder for anything to enter the canal from inside the abdomen. So you get compression along the canal and closure of the deep entrance. It's a brilliant dynamic defense.
And when this mechanism weakens or fails due to nerve damage, muscle atrophy, or chronic strain,
then the stage is set for acquired hernias, both direct and indirect, to develop or worsen. Understanding this dynamic aspect is key to appreciating why factors like chronic cough or constipation contribute to hernia formation. They constantly challenge this shutter mechanism.
that deep understanding really elevates things.
Yeah.
Okay, now let's clearly distinguish the two main types of inguinal hernias based on their anatomical path relative to those epigastric vessels.
Right. The key landmark is the deep inferior epigastric artery and vein. An indirect inguinal hernia enters the inguinal canal through the internal deep ring, which lies lateral to the inferior epigastric vessels.
Lateral to the vessels through the deep ring and its origin.
Indirect hernias are fundamentally congenital, even if they don't manifest until adulthood. They result from a failure of the processus vaginalis, that embryonic outpouching of peritoneum that accompanies the testis descent to completely obliterate after birth. A patent processus vaginalis provides a preformed sac extending into the inguinal canal, ready for abdominal contents to enter. In females, the equivalent structure is the canal of Nuck.
Okay, so indirect congenital through the deep ring lies lateral to vessels. Now, direct.
A direct inguinal hernia, in contrast, does not enter the deep ring. It pushes directly forward through the weakened floor of Hasselbalch's triangle, medial to the inferior epigastric vessels.
Medial to the vessels through the weak floor. Acquired.
Generally considered acquired, resulting from the breakdown and attenuation of the transversalis fascia in Hasselbalch's triangle due to chronic strain, aging, or tissue weakness.
And occasionally you can see both at the same time.
Yes, that's called a pantaloon hernia, where you have both an indirect component entering the deep ring and a direct component bulging through Hasselbalch's triangle simultaneously, straddling the inferior epigastric vessels like a pair of pants.
Got it. Okay, let's move on to repair strategies, starting with the traditional open tissue repairs, no mesh involved. These are still essential in certain situations, right?
Absolutely essential, primarily in pediatric surgery, where indirect hernias are almost always due to a patent processus vaginalis only, requiring just high ligation of the sac. Also, tissue repairs are mandatory in contaminated settings, like if a hernia is strangulated and requires bowel resection, where putting in mesh would carry an unacceptably high risk of infection.
So what are the main tissue repair techniques?
The gold standard for non-mesh repair in adults based on lowest recurrence rates in comparative studies is the Schultes repair. Developed at the Schultes Hospital in Canada, it's a meticulous, multi-layered repair.
4 layers.
Essentially, yes. It involved incising the attenuated transversalis fascia, creating superior and inferior flaps, and then performing a 4-layer imbricated closure, suturing these flaps along with the internal oblique transversus abdominis arched down to the inguinal ligament or iliopubic tract. It aims to reconstruct the posterior wall in layers.
Sounds complex.
It requires specific training and is technically demanding, but when done well, it has excellent results. International guidelines consistently recommend the Schultes technique if a non-mesh repair is chosen.
What about the Bassini repair? That's an older name we hear.
The modified Bassini repair is simpler but generally has higher recurrence rates than Schultes. It essentially involves approximating the arching fibers of the internal oblique and transversus abdominis, or the conjoint tendon if present and strong, directly down to the shelving edge of the inguinal ligament with interrupted sutures.
Tension issues.
Yes, tension can be a significant issue with the Bassini, often necessitating a relaxing incision made vertically in the anterior rectus sheath medially to allow the tissues to come down to the inguinal ligament without undue strain.
Okay. But let's be realistic. The vast majority of adult inguinal hernia repairs today, especially in developed countries, are mesh-based, aiming for a tension-free approach.
That's correct. The introduction of prosthetic mesh revolutionized hernia repair by dramatically reducing recurrence rates compared to most tissue repairs, largely by avoiding tension on the suture lines.
What are the main open mesh techniques?
The current workhorse and widely preferred open mesh technique is the Liechtenstein repair. This involves placing a flat sheet of prosthetic mesh on top of the posterior wall of the inguinal canal and onlay position. The mesh bridges the defect in Hesselbach's triangle and reinforces the area around the deep ring.
Simple onlay batch, preferred over plug and patch.
Yes, it's generally preferred now over the older Rutkow and Robbins technique, which used a cone-shaped mesh plug inserted into the deep ring for indirect hernias, in addition to an onlay patch. The Liechtenstein avoids the plug, reducing the amount of foreign material, potentially lowering risks like mesh migration or erosion, and reducing cost while achieving similar excellent outcomes.
What's the most critical technical detail for a successful Liechtenstein repair regarding the mesh?
Mesh overlap. This is absolutely key. The mesh patch must be sized appropriately so that it extends well beyond the boundaries of the hernia defect itself. The standard recommendation is for the mesh to overlap the healthy fascial edges by at least 3 to 4 centimeters circumferentially.
Why so much overlap?
Two main reasons. First, meshes can shrink slightly over time as they incorporate. Second, and more importantly, this wide overlap ensures that even with patient movement or straining, the forces are distributed over a wide area of healthy tissue, preventing the mesh from pulling away from the edges or allowing a recurrence around the periphery of the mesh. Adequate overlap is crucial for long-term durability.
Makes sense. Now, we must specifically address femoral hernias. They're less common than inguinal, but distinct and dangerous because of their immediate proximity to the major femoral vessels.
Exactly. A femoral hernia is a protrusion of abdominal contents through the femoral ring. This ring is the narrow superior opening into the femoral canal.
And the femoral canal is?
The femoral canal is the small, most medial compartment within the femoral sheath, which is itself a downward extension of the transversalis and iliopsoas fasciae from the abdomen. The canal normally contains just some lymphatic tissue, including a lymph node called Klipke's node and some loose areolar tissue. Its main purpose seems to be allowing the adjacent femoral vein, which is just lateral to it, space to expand during increased venous return.
So the hernia comes through that medial compartment's entrance. Why are they more common in women?
Femoral hernias are significantly more common in women, likely due to the generally broader shape of the female pelvis, which results in a slightly wider femoral ring, offering less resistance to herniation.
And their danger.
Critically, femoral hernias have the highest risk of strangulation among all abdominal wall hernias. This is because the femoral ring is bounded by rigid structures. The inguinal ligament anteriorly, the lacunar ligament medially, the pectineal Cooper's ligament posteriorly, and the femoral vein laterally. Once bowel enters this tight space, it can easily become trapped and its blood supply compromised. A tender lump below the inguinal ligament should always raise high suspicion for a strangulated femoral hernia.
Okay, high risk. So when repairing them with open surgery, the choice of approach often depends on whether it's an elective case or an emergency with suspected strangulation, right?
Precisely. The clinical setting dictates the strategy. There are 3 main open approaches.
Approach 1.
Lockwood's infrainguinal approach. This is done entirely below the inguinal ligament. It avoids disrupting the inguinal canal itself, which is an advantage. However, gaining control of the hernia neck high up can be difficult if the hernia is incarcerated or strangulated, often preferred for elective, straightforward cases.
Approach 2.
Lotheson's transinguinal approach. Here, the surgeon opens the inguinal canal floor from above, similar to an inguinal hernia repair, accesses the femoral canal from within the inguinal canal, reduces the hernia, and repairs the defect, often by suturing the conjoint tendon or iliopubic tract to Cooper's ligament. It gives good control of the neck, but slightly risks creating a subsequent direct inguinal hernia due to disrupting the canal floor.
And approach 3, especially for emergencies.
McEvery's high approach. This involves making an incision superior to the inguinal ligament, often a vertical incision extending upwards from the medial end of the ligament, sometimes even going paramedian through the rectus muscle. This approach provides the best access for emergencies, particularly suspected strangulation.
Why is it best for emergencies?
Because it allows the surgeon to gain immediate control of the hernia neck from above within the peritoneal cavity or preperitoneal space. This means they can assess the viability of the trapped bowel before attempting to reduce it. If bowel resection is needed, it can be done safely intra-abdominally before dealing with the contaminated hernia sac below. It gives the most direct control in critical situations.
Excellent overview of the approaches. And let's reiterate that mesh warning in contaminated cases.
Absolutely critical. If, during the repair of any hernia, femoral or inguinal, the surgeon finds that the bowel is non-viable and requires resection, or if there's perforation and gross contamination, the use of permanent prosthetic mesh is absolutely contraindicated. Because placing mesh in a contaminated field carries an extremely high risk of developing a deep-seated chronic mesh infection, which is a devastating complication, often requiring multiple further surgeries to remove the infected mesh. In contaminated settings, the surgeon must revert to a primary tissue repair, like the McVeigh repair, suturing conjoint transversus arch to Cooper's ligament for a femoral hernia, even though the recurrence risk might be slightly higher than with mesh. Safety first.
Suture repair only if contaminated. Got it.
Stay.
Okay, let's pivot finally to laparoscopic repair of inguinal and femoral hernias. Techniques like TAPP and TEP are now often preferred, especially for bilateral or recurrent hernias.
Yes, laparoscopic approaches offer benefits like reduced postoperative pain, quicker return to activity, and the ability to address bilateral hernias through the same small incisions. They both aim to place a large piece of mesh in the preperitoneal space behind the entire inguinofemoral complex, reinforcing all potential hernia sites, direct, indirect, femoral, simultaneously.
Briefly differentiate TAPP and TEP.
TAPP stands for transabdominal preperitoneal repair. In this approach, the surgeon enters the peritoneal cavity first, just like for other laparoscopic procedures. Then they make an incision in the peritoneum overlying the inguinal region, dissect down to create a preperitoneal pocket, reduce the hernia sac, place the mesh in the pocket, and finally close the peritoneal incision over the mesh.
So goes inside the main abdomen first. And TEP.
TEP-P stands for totally extraperitoneal repair. This technique avoids entering the peritoneal cavity altogether. The surgeon uses a balloon dissector or blunt dissection to create a working space directly within the peritoneal space between the peritoneum and the overlying transversalis fascia muscles. The entire dissection, hernia reduction, and mesh placement occur within this space, keeping the peritoneum intact below.
Advantages of TEP.
TEP is technically more challenging to learn because the working space is tighter and landmarks can be less clear initially. However, its theoretical advantages include a potentially lower risk of intra-abdominal complications like bowel injury or adhesion formation, since the peritoneal cavity itself is never violated. Both TAPP and TEP-P, when performed correctly, yield excellent results.
Now, regardless of whether it's TAP or TTP, the laparoscopic view from inside looking out reveals those critical danger zones, often framed by the peritoneal coverings of ligaments. Let's orient ourselves with those 5 inner ligaments first.
Right. From the preperitoneal or intra-abdominal view, you see these folds or ridges in the peritoneum. Medially, there's the single median umbilical ligament, the urachus remnant. Flanking it are the 2 medial umbilical ligaments, remnants of the obliterated umbilical arteries. Further laterally on each side are the lateral umbilical ligaments, which are simply the peritoneal folds raised by the underlying functional deep inferior epigastric arteries and veins. These 5 ligaments folds are key landmarks.
Okay, now the danger zones. Let's start with that notorious vascular variant, the corona mortis.
The crown of death. This isn't always present, but when it is, it's a major hazard. The corona mortis is an anomalous vascular anastomosis, typically occurring between the obturator artery system, which usually comes off the internal iliac, and the external iliac or inferior epigastric system.
Where does it run?
It runs transversely across the superior pubic ramus, often lying directly along the deep surface of the pectineal Cooper's ligament, and sometimes the lacunar ligament, right near the femoral ring.
And its clinical significance.
Its main clinical significance arises during surgery around the femoral ring, particularly during attempts to release a strangulated femoral hernia by incising the rigid medial boundary, the lacunar ligament. If a surgeon blindly cuts medially through the lacunar ligament to widen the femoral ring and an underlying corona mortis vessel is present, they can cause catastrophic, often difficult to control hemorrhage deep in the pelvis from this aberrant vessel. You must be aware of its potential presence.
Avoid cutting medially into the lacunar ligament blindly. Got it. Now for the two key zones of risk during laparoscopic mesh placement and fixation. The triangle of doom and the triangle of pain. Let's start medially with doom.
The triangle of doom is the medial danger zone, primarily concerning vascular structures. It's roughly bounded by the vas deferens medially, or the round ligament in females, the gonadal vessels, testicular or ovarian artery and vein, laterally, and the reflected peritoneal edge inferiorly.
And what lies within this triangle?
This small area directly overlies the major external iliac artery and vein. It also contains the origin of the deep circumflex iliac vein. Placing staples or tacks for mesh fixation within this triangle carries a significant risk of major vascular injury and potentially life-threatening retroperitoneal hemorrhage. Avoid tacks here is the mantra.
Triangle of doom, medial vessels, no PM adults, no tacks. Okay. Now laterally we have the triangle of pain.
The triangle of pain is the lateral danger zone, primarily concerning neural structures. It's bounded medially by the gonadal vessels again, forming a shared border with the triangle of doom, superior laterally by the curving iliopubic tract, and inferiorly near the acis and iliac crest region.
And what nerves are hiding here?
This triangle contains several important nerves supplying the leg and groin. The femoral nerve lies just lateral to the artery, though slightly deeper. The lateral femoral cutaneous nerve, supplying sensation to the anterolateral thigh, runs more superiorly and laterally towards the acis, and the femoral branch of the genitofemoral nerve, supplying sensation to the upper anterior thigh, is also found here.
So tacks here cause.
Tacks or staples placed in the triangle of pain risk injuring these nerves, leading to immediate postoperative pain, numbness, paresthesias, like burning or tingling, think neuralgia paresthetica from lateral femoral cutaneous nerve injury, or even devastating motor deficits like quadriceps weakness from femoral nerve injury. Again, the rule is avoid tacks here. Mesh fixation laterally should be done very carefully, often using absorbable tacks or no tacks at all above the iliopubic tract laterally.
Triangle of pain, lateral nerves, no tacks. Very clear warnings. You mentioned the genitofemoral nerve. What about its genital branch? Is that also at risk?
Yes, the genital branch of the genitofemoral nerve, which runs with the spermatic cord structures through the deep ring, or near the round ligament in females, is also highly vulnerable during dissection around the deep ring and cord structures. Injury here primarily causes loss of the cremasteric reflex in males and altered sensation in the scrotum or labia majora, contributing to chronic groin pain, genitofemoral neuralgia.
Speaking of nerve pain, the ilioinguinal nerve is often cited as the most common culprit for chronic postoperative neuralgia after open inguinal hernia repair. Where is it most vulnerable?
The ilioinguinal nerve, along with the often closely associated iliohypogastric nerve, is most vulnerable during the initial steps of an open repair. As it emerges from laterally, it pierces the internal oblique muscle and then runs superficially, just deep to the external oblique aponeurosis, often very close to the external inguinal ring.
So vulnerable during opening and closing.
Exactly. It can be injured by retraction during dissection, trapped in sutures when closing the external oblique aponeurosis, or irritated by the mesh itself. It's the most frequent cause of chronic burning groin pain radiating to the scrotum labia or upper inner thigh after open surgery.
Is there a strategy to prevent this?
It's controversial, but there's growing evidence supporting a proactive approach. Several studies have actually demonstrated that performing a planned prophylactic neurectomy, intentionally identifying and excising the ilioinguinal nerve during the primary open repair, can significantly reduce the incidence of debilitating chronic postoperative neuralgia compared to trying to meticulously preserve it. It's a trade-off: predictable numbness versus unpredictable chronic pain.
Interesting approach. Finally, one last complication risk, particularly in male patients undergoing inguinal hernia repair. Ischemic orchitis.
Yes, this is a rare but serious complication resulting from compromised blood supply to the testicle, which travels within the spermatic cord, testicular artery, pampiniform plexus of veins.
How does it happen?
It can occur due to excessive dissection and handling of the spermatic cord structures, leading to vasospasm or thrombosis of the delicate vessels. It's also more likely if the repair creates excessive tension around the cord at the deep ring, or, more commonly, if the external inguinal ring is closed too tightly around the emerging cord during closure of the external oblique aponeurosis.
So gentle handling and avoiding a tight closure.
Precisely. Surgeons must minimize unnecessary dissection of the cord itself, no touch technique where possible, and ensure that the reconstructed external ring allows comfortable passage of the cord without constriction, often calibrated by being able to easily insert the tip of a forceps alongside the cord. Preventing ischemic orchitis preserves testicular function and avoids testicular atrophy.
Okay, we've journeyed through the embryology, mapped the layers, navigated the neurovascular hazards, detailed the hernia repairs. To truly complete this mastery deep dive, we absolutely must discuss the final critical step, the evidence-based best techniques for actually closing the abdominal wall, specifically midline laparotomy incisions, to ensure long-term security and minimize those dreaded complications of dehiscence and incisional hernia.
This is incredibly important. Midline closure is one of the most common procedures surgeons perform, yet doing it incorrectly is a major source of patient morbidity. The evidence accumulated over recent years gives us some very clear guidelines on how to do it best.
Let's break it down. First, the choice of suture material itself. What does the evidence favor?
The evidence strongly favors using a slowly absorbable monofilament suture. Examples include polydioxanone, PDS, or polyglycinate, Maxen.
Why slowly absorbable monofilament?
2 reasons. The monofilament nature means less tissue drag and, theoretically, a lower risk of bacterial harboring compared to braided sutures. More importantly, the slow absorption profile, maintaining significant tensile strength for several months, allows the fascia ample time to heal properly before the suture fully degrades. Studies consistently associate the use of slowly absorbable monofilaments with significantly lower rates of incisional hernia compared to older, rapidly absorbable sutures like polyglycolic acid, Vicryl, or chromic gut.
Okay, slow monofilament like PDS. Second, the technique of closure. Should we be closing in layers, peritoneum separately, or doing a mass closure of the fascia?
This was debated for a long time, but the consensus now, strongly supported by bodies like the European Hernia Society, EHS, in their guidelines, is to use a single-layer aponeurotic closure technique.
Just the fascia.
Just the fascia. This means taking bites only of the strong anterior rectus sheath, or the fused linea alba. The guidelines explicitly advise against separately closing the peritoneum.
Why not close the peritoneum? Doesn't that add a layer?
It adds a layer, but studies have shown it adds no measurable tensile strength to the overall repair. It takes extra time, introduces more foreign material suture into the abdomen, which could promote adhesions, and carries a small risk of inadvertently injuring underlying bowel during peritoneal closure. So, the recommendation is clear. Close the fascia only in a single, strong layer.
Single layer fascial closure. Got it. Now, probably the most pivotal change in technique in recent years came from that landmark STICH trial. It completely changed how we think about the size of the suture bites we should be taking.
Absolutely. The STICH trial was practice-changing. The traditional approach, taught for decades, involved taking large bites of fascia, typically placing sutures about 10 millimeters, 1 centimeter, back from the fascial edge, with similar 10-millimeter intervals between sutures.
The 1 centimeter rule.
Right. What the STICH trial convincingly demonstrated was that a small bite technique is significantly superior for preventing subsequent incisional hernia development.
Define small bite.
Small bites mean placing the sutures much closer to the fascial edge, only about 5 millimeters back from the edge, and also using much closer intervals between the sutures, again around 5 millimeters. So more numerous, smaller, closer bites compared to fewer, larger, wider bites.
And the biomechanical reason why small bites are better.
It's all about tension distribution. The traditional large bites tend to concentrate the tension at fewer points along the incision, which can lead to tissue strangulation, ischemia at the suture points, and eventual suture pull-through or fascial tearing, especially when the patient coughs or strains postoperatively.
Creates weak spots.
Exactly. The small bite technique, with its more frequent points of fixation, distributes the tension much more evenly and gently along the entire length of the wound edge. This leads to better tissue perfusion, improved healing, less risk of suture pull-through, and ultimately a stronger, more durable long-term scar with a lower hernia rate.
More stitches, less tension per stitch. Makes perfect sense. And underlying all of this, there's their critical ratio everyone talks about. The suture length to wound length ratio.
Yes, the final piece of the puzzle for optimal closure is maintaining a suture to incision length ratio of at least 4:1.
3:1, meaning
Meaning the total length of the suture material you actually use to close the fascial incision must be at least 4 times the measured length of the fascial incision itself. So for a 20-centimeter incision, you need to use at least 80 centimeters of suture.
why is this ratio so important?
Achieving this ratio generally ensures that you're taking sufficiently small bites with close enough intervals, as we just discussed, without creating excessive tension on any individual bite. If your ratio is much less than 4.1, it implies you're likely taking bites that are too large, too far apart, or pulling the sutures too tight, all of which increase the risk of failure. Adhering strictly to all these principles using a slowly absorbable monofilament, employing a single-layer fascial closure, mastering the small bite 5 millimeter technique, and ensuring a suture length to wound length ratio of at least 4.1 represents the current evidence-based gold standard for minimizing incisional hernia after midline laparotomy.
Wow, that is a truly comprehensive framework for closure. This entire deep dive has been incredibly detailed and I think exceptionally variable. We started right back at the beginning, understanding how developmental failures in embryology lead to defects like omphalocele and gastroschisis.
Oh.
We meticulously mapped the critical 3 zones of the rectus sheath, which dictates closure strategy.
Ooh.
We discuss high-stakes vascular anatomy, like the potential for the deep inferior epigastric artery to act as essential leg collateral.
The crucial clinical point.
And we finished by navigating the truly complex and hazardous geometry of the inguinal region, identifying those vital landmarks and rigorously defining how to avoid the triangle of doom and the triangle of pain during repair.
It really highlights that achieving true mastery in this area means getting beyond just lists of structures. It's about understanding the story of this anatomy.
The story.
Yeah, why is the linea alba weak inferiorly?
Yeah.
Why does the shutter mechanism work the way it does? Why are transverse incisions often better cosmetically but carry specific nerve risks laterally? Why does small bite closure offer superior biomechanical results? It's connecting the structure to the function and the failure modes.
So what's the final takeaway for everyone listening who wants to operate safely and effectively in this region?
We spent a lot of time today discussing how the abdominal wall, particularly around the inguinal canal with its shutter mechanism, relies so heavily on the precise, coordinated tension and contraction of muscles like the transversus abdominis and internal oblique to provide dynamic defense against herniation. It's not just passive structures holding things back.
Right, the dynamic defense.
So my provocative thought for you to ponder as you go about your clinical work is this. Beyond the abdominal wall, what other critical load-bearing anatomical structures in the human body, maybe think about the spine or the pelvic floor or even joints, rely primarily on such a sophisticated, dynamic, muscle-driven, tension-based defense mechanism, rather than just relying on purely passive static structures like bone or ligaments to prevent catastrophic failure under load?
Where else does active muscle tension provide the primary defense against structural failure?
Exactly. Think about that concept of tension-based defense as you look at other parts of the body. It might change how you view their stability and function.
That's excellent food for thought. A fantastic way to wrap up. Thank you so much for guiding us through this absolutely essential, incredibly detailed deep dive into surgical anatomy today.
It was my pleasure. It's fundamental anatomy, always worth revisiting.
And thank you, our listeners, for joining us on the deep dives. We'll see you next time.